A very good evening to all of you, to all the delegates and senior colleagues. It's a pleasure to have you all on board for this edition of the ASSI Conference 2021. Trust you all have had a safe year and a happy new year to all of you. We have a wonderful opportunity here today to sit down and have an open discussion with legends in spine surgery. And I can think of no one who fits the description more aptly than Dr. Fehlings. Dr. Fehlings is an internationally known spine surgeon. He is a highly revered figure in the field of neurosurgery and spine surgery. He is currently professor of neurosurgery at the University of Toronto. He is vice chair of research at the university and is also the co-director of the Spine Fellowship Program. Dr. Fehlings balances a very busy clinical practice where he performs complex spine surgery alongside cutting-edge research program. He heads a multidisciplinary team of researchers looking into novel treatment options for both traumatic as well as non-traumatic spinal cord injury. He has been the recipient of a very, very long list of awards and accolades, too long for us to fit into this 20-minute session. He also has 900 peer-reviewed publications to his credit. In addition to all this, all of us who've had the distinction of being Dr. Fehlings' fellows know that he is an avid skier and a great host. Dr. Fehlings, welcome aboard and thank you so much for sparing time to be with us. I know that everybody in this audience knows you well. You have been a frequent flyer to India. You've traveled to Chennai, Mumbai. I know that you've been to Agra. Now, we welcome you back to India virtually. Now, over the next 20 odd minutes, we've decided that we will engage with you on three topics. The first one is some of your thoughts on recent updates in the management of traumatic spinal cord injury. Do let us know what your team and yourself, what new updates have been. As you're aware, traffic in India is chaotic. We have a lot of road traffic accidents, and a lot of our patients want to know what is path breaking, what's up to date. And we'd like to hear from you on that. We'd then move on to some of your recent thoughts on the RECO DCM project, as well as other updates on the management of degenerative cervical myelopathy, particularly when you have old and frail patients, which most of them are, but your experiences on the nuances of management of such patients. And then we'd end the session with your advice to us on how you've managed to balance your career as a preeminent surgeon scientist. So welcome, and I'd hand over the session to you, and I'd ask you to first share your thoughts about current updates in the management of spinal cord injury. Dr. Fehlings.
Thank you very much for the kind remarks and for the invitation to take part in this ASSI session. And Rohit, it's a particular pleasure to have the opportunity to have this discussion with you. It's wonderful for me to see your own successes and many fellows that I've trained who are in India. And it's wonderful to have developed these friendships with India. So on the topic of spinal cord injury, what's new, what's hot, where are we going? The role and timing of surgical intervention for spinal cord injury has evolved considerably from where patients were generally managed non-operatively, and then if surgery was done, it was done generally in a delayed fashion. We've now evolved. In late December of last year, so just less than a month ago, our group published a major article in Lancet Neurology, where we did an analysis on over 1,500 patients prospectively accrued with all forms of traumatic spinal cord injury. And we showed very clearly and quantitatively that early surgical intervention within 24 hours was associated with significant improvements in motor recovery, sensory recovery, and conversion on the Asia impairment scale. And for the first time, within the first 24 hours, we were actually to show a linear relationship between the timing of intervention and recovery. So I think that this paper really nails the question of whether decompression helps and whether early decompression is of value. Now, the challenge is how to apply this knowledge. There are major logistical challenges. The patients are sick. In countries such as India, there can be transportation issues. Sometimes centers can be overwhelmed with the numbers of patients that arrive, and the logistics too need to be ironed out. But what is clear is that surgical intervention is of assistance. And I think the challenges now are to look at practical approaches to translate this knowledge and to develop the systems in place to facilitate transportation of the patients and access to the operating theaters and the imaging studies to do this. This work also validates the concept that time is spine. So the timing of intervention becomes critical. And we have seen the impact of such interventions in stroke, where the early interventions for stroke, for example, with antithrombolytic therapies, have had a dramatic impact on outcome. And so I think that this is going to be our next challenge over the next 5 to 10 years. In addition, from a surgical perspective, we still need to consider what represents inadequate decompression, what is the role of post-operative imaging, and what is the role of more advanced monitoring approaches. So, for example, there has been work done on duroplasty. So should duroplasty be done in patients with an acute spinal cord injury? Probably not in everyone, but perhaps there's a subset of patients. High-resolution intraoperative ultrasound could be an approach that could facilitate this. What about the use of intrathecal catheters to measure intraspinal pressures, potentially to drain cerebrospinal fluid, and to treat an acute spinal cord injury in an analogous fashion to how a traumatic brain injury is treated, where we have catheters to measure pressure and we can titrate blood pressure management specifically to the patient as opposed to guessing on the numbers. And the hemodynamic management in the acute phase will likely undergo intervention. As a first principle, it has been suggested that hypertensive management be used for 7 days. But do all patients require this? Will all patients tolerate this? Well, a patient with recovering incomplete spinal cord injury probably does not need 7 days of hypertensive management. And generally, we would use such management for about 2 to 3 days. And then what about older patients that may have less tolerance for inotropic agents? So I think the intensive management will evolve. And I mention this because this is very practical. This is something that we can do now and that really needs to be looked at. And this is also a shout out to the trainees in the audience, that these are questions that one can look at. And while the application of this can be challenging in the huge Indian subcontinent, nonetheless, I think one should aspire to try to elevate the level of treatment. So what else is going on in the field of spinal cord injury? Well, there are advances in rehabilitation, for sure. And we now recognize that targeted physical therapy and electrical stimulation can potentially facilitate repair and neural plasticity. So, for example, hand and upper extremity function in a quadriplegic individual. It's now recognized that therapeutic and functional electrical stimulation in the upper extremity can act in combination with intensive rehabilitation, can facilitate partial recovery of hand and upper extremity function. And if you combine this with a good decompression and surgical stabilization, this really could have an impact on patients. Then longer term, I see a new specialty arising in spine surgery, and this is where we see surgeons who perhaps have dual training in spine surgery and in functional neurosurgery. So what do I mean by this? So for example, the use of electrical stimulation applied extradurally in the thoracolumbar area of the spine to stimulate the locomotor central pattern generators to facilitate recovery of walking. So to be able to do this, and this requires good research to validate this. Right now, I think this is an interesting concept, but there's been no randomized trial. We have not seen this validated, but nonetheless, the science behind this is quite good. So to do this, one needs surgeons who understand spine surgery, understand spinal cord injury, but also have the skill sets to do the functional neurosurgical aspects of this. So that becomes an interesting area in evolution. Now, where are we with regenerative medicine and the application to patients with spinal cord injury? And Rohit, I'm sure you have many patients coming into your practice years after an injury. I do as well. And to be frank, right now in 2021, we don't have a lot to offer these patients that's truly validated. And I think we need to be clear about this. But what's on the horizon? We're at an inflection point in regenerative medicine, and the science is now remarkable. And so here's where we are and where we're going to be going in the next 5 years. We have now the ability to generate customized neural stem cells for any person that are specific for that person, using either direct reprogramming or induced pluripotent cell technologies. And so you could take a blood cell or a bone marrow cell, expand this in culture, and make this into a neural stem cell. But in addition, there are technologies now where the cells can be genetically engineered to release factors that will degrade the glial scar in a chronic injury, and also release growth factors to facilitate the integration into the neural environment and the reconstruction of neural circuits. And this work is now in late stage preclinical development. Our group in Toronto is leading this along with other groups around the world. And I anticipate in the next few years, we will be seeing significant advances in the application of these advanced regenerative technologies to people. Coming back to the acute injury, where are we with neuroprotective drugs? And I've been very actively involved with trying to translate an existing therapeutic called riluzole. Riluzole is used by the neurologists for ALS, and it reduces nerve cell degeneration. Well, we're 2/3 of the way through the recruitment in a major randomized trial called the RISCUS trial. It's a riluzole and spinal cord injury study with 193 patients recruited. We had to stop enrollment for a few months because of COVID. And so we took the opportunity to undertake a pre-planned interim analysis of the data. And I'm excited to reveal that the data look very promising. And we have a positive signal, and we've been strongly encouraged to continue enrollment in that study. So it's possible that clinicians in a few years will have an effective neuroprotective drug, which could help also to facilitate neural repair and plasticity. So maybe I'll just stop there. There are many other advances that are occurring, but that might give a nutshell perspective on where I see the field evolving.
I have thank you for that. I have two quick remarks to make to you. The first is that I remember in 2014, I think it must have been the month of May, April or May, we had, there was a patient who had presented to the hospital, and under your leadership, the team had proceeded with stem cell therapy for a lady who had a spinal cord injury. How did that pan out over the next many years? I mean,
Oh, yes. So thank you for reminding me about that. And I continue to follow these patients. So this was one of the first examples of a high-level trial with what I might call the first generation of neural stem cells. The patient in question showed a modest level of neurological recovery. She recovered some sensation. Unfortunately, this did not translate into meaningful functional recovery for her. We've recently published the results of these data, and this was done in collaboration with Armin Kurt in Zurich and a number of other investigators around the world. These were allogeneic neural stem cells from a cell bank, so they weren't matched to the patient, and they were not genetically modified to alter the environment. So what this showed us was that we could safely introduce the cells. There were no adverse consequences in the patients, and there was evidence in most patients of some neurological changes. However, the changes that we observed were modest. The patient I'm describing was typical. So what have we learned from this? So we've learned that we can do this safely, and the regulatory authorities now accept this as a legitimate area of investigation. But we've also learned the limitations of the neural stem cells. So they help, but they're not the magic cure-all. And it's now recognized what additional improvements need to be made to the neural stem cells. And specifically, I think there's an advantage to having a personalized approach where you're using the person's own stem cells that are genetically engineered. And then secondly, I think it's important that the cells are engineered to overcome the inhibitory microenvironment, either the glial scar or various inhibitory factors that are in the spinal cord. And so scientists have now gone back to the bench to try to figure this out. There have been many scientific advances that have occurred, and we're now seeing a number of groups, ourselves in Toronto, groups in Japan and in California, are starting to advance this into early phase preclinical trials. And then I envision over the next couple of years, we're going to be seeing clinical trials emerging in this area.
Thank you so much, Dr. Fehlings, for that quick overview. I know that this is an exhaustive topic. You've spent, a lifetime doing this work, and 6 minutes never does justice to this. I appreciate that, and I also appreciate you for the time that you spent. We have a couple of minutes left, and I'm going to quickly race you through DCM. I mean, is there, in 1 minute, can you tell us, what's updated now on the DCM front, on non-traumatic spinal cord injury?
So it's recognized that degenerative cervical myelopathy is the commonest cause of non-traumatic spinal cord injury, spinal cord impairment in the world. So we now have an overarching term which encompasses things such as cervical spondylotic myelopathy, OPLL, and we're trying to unite the field to raise awareness. And so one of the biggest issues here is to raise awareness among patients, among general practitioners. Surgical treatment is effective, and for people with moderate and severe impairment, it's imperative really that these patients be treated in as early a fashion as possible. The conundrum that we're faced with is how to manage mild cervical myelopathy, the patients that come in with impressive imaging findings, but very little to find on a clinical examination. And right now, the best that we can do is to follow the patients and then to consider things on an individual basis through a shared decision-making approach. But what's going to be coming forward is that we will be able to have imaging biomarkers as well as serological and genetic biomarkers that are going to be able to allow targeted treatment. So for example, some of the imaging biomarkers relate to microstructural MRI, and we've recently published work showing that a metric called T2 star, white matter to gray matter signal ratio, is quite helpful in discerning patients who are at higher risk for neurological deterioration. And it's recognized that there are certain genetic biomarkers which can predict outcomes. We have a paper coming out in Brain on the use of microRNAs, and these can be measured in patients. And so patients who express certain types of microRNAs are at higher risk for deterioration. And so potentially through a blood test and through an MRI examination, you can now, in the future, counsel patients in terms of this, the recovery. Riluzole has also been studied in DCM, and in December of last year, we also published the results of our CSM Protect randomized trial with riluzole. And we found that while there was not an added benefit to recovery on the MGOA scale, interestingly, the patients who received riluzole had better outcomes with regard to pain, which was a bit unexpected, but it actually makes sense. And so riluzole is, I think, an option that I would invite physicians to look at, particularly in those with neuropathic pain. And this could be something that could have an added benefit to our patients. Finally, a shout out to a project called RECODE, which is an effort being led by AO Spine International in collaboration with a former fellow of mine, Mark Cotter at Cambridge University. And through RECODE, we are embarking on a knowledge translation process to raise awareness of degenerative cervical myelopathy, to identify critical research priorities, and then also to develop a minimal core data set that can be used by researchers and clinicians to collect data and to advance the field.
Thank you very much, Dr. Fehlings. Thank you so much. We're running out of time. I expected this. You expected this. I sort of just want to summarize the session. Thank you for your comments on early surgery. Thank you for your reminder to all of us in India that we need to sort of have smoother transport systems in place where patients have better imaging access. Your comments about riluzole are well received. I know it's not an expensive drug. I know that our neurologists use it for ALS, and so we have access to it. The RECODE DCM emails have been obviously accessible to us. Mark Cotter has been one of my co-fellow post-assessors at Toronto, and the program I know runs well under your guidance, and Mark and Benjamin Davis have been doing a great job there. The article by Fehlings, Badiwala et al. On early DCM and surgery was read at one of our journal clubs, and it was very well received at our paper reading, and thank you very much for that. So we will have the floor open to our delegates. If any of you have questions for Dr. Fehlings, please field them in the chat box, and then we will try and pass them on to Dr. Fehlings. And if there are questions that he will answer, then we will certainly share them with you. Thank you very much once again. Good morning to Dr. Fehlings, and good evening and good night to everybody here in India. Thank you very much.
Thank you. Thank you very much.
Thank you, Dr. Fehlings. Thank you, Rohit. That was a wonderful interview and a lot of insights into pathologies of the spinal cord and degenerative cervical myelopathy. Dr. Fehlings, we would be grateful if you could be around for the next 10 minutes or so, because there will be questions on the chat box which will start coming slowly, and then there will be a huge rush of questions which people will want to ask you. So if you could stay back, and we would move on to the next interview, and that is of Dr. Vijay Lahiri and Dr. Atul Goyal, Head of Department of Orthopedic Surgery and Neurosurgery at KEM Hospital in Bombay. And they will be interviewed by their student and now a teacher in his own right, Dr. Samir Dalvi.
Okay.